So I wanted to thank you guys for the opportunity to present an overview of spinal dysraphism, something that's near and dear to many pediatric neurosurgeons' practice and heart in general. And I'll touch on a few of the topics I think you're going to hit in later lectures, but not to any meaningful degree. So hopefully it'll just scratch the surface and get you thinking a little bit. So here are my disclosures, none of which are pertinent to any of the topics I'll be talking about today. And just kind of a brief outline. This comes from some of the materials I was given. So we'll talk a little bit about the pathophysiology of spinal dysraphism, including some of the major embryological processes. This isn't going to be like your MS1, MS2 embryology course, but just kind of general ideas and themes when you think about neural tube defects as it relates to surgical anatomy and management. We're going to talk a little bit about epidemiology and natural history of the main categories of spinal dysraphism. And we'll talk about the diagnostic evaluation, not in specifics, but in generalities, because you'll find for many of these kids, the theme is the same, and some of the clinical and radiographic features that we look at certainly go along with that. We'll talk about some of the main patterns of presentation, symptomatic versus asymptomatic, and talk about treatment options and specifically when you should not treat and just observe. So when we talk about spinal dysraphism, really the term spinal dysraphism is kind of a blanket, and for lack of a better term, it's kind of a wastebasket term, right? So we think of things like neural tube defects, and when I talk about neural tube defects, these are really congenital anomalies with defects in the dorsal midline structures. And the dorsal midline structures include neural tissue, dura, muscle, bone, skin, and along with these blood vessels that are associated with all of these structures. And the primary embryological defect or failure is because of incomplete neural tube closure. So as you all know, neural tube closure occurs really during the third or fourth week of life. And with neural tube defects, there can be a wide range of presentation and severity. And as a result, there's a wide range of neurological symptoms and potential deficits. And so that's why seeing the patient and evaluating their neurological function is really, really important. These most commonly involve the lumbosacral spine, and the incidence of, again, this kind of all-encompassing term of spinal dysraphism is really 0.05 to 0.25 per 1,000 live births annually. So when you think about the impact of spinal dysraphism and what our role is as pediatric neurosurgeons in diagnosis and management, you really want to make a correct diagnosis, because that really has implications in terms of surgical treatment. And you also want to consider the potential management options, the potential surgical treatment, and education and counseling on the potential need for lifelong care, which is super important when you talk to these families. Oh, excuse me. So when I think about things, I like to make things as simple as possible. And so when you think about spinal dysraphism, there's all kinds of categories and different ways of thinking about things in terms of embryology and subsequent management, presentation, cell lines, things like that. But I like to think of these in a very simple way in two categories. So open, or what you might have known as spina bifida aperta, and then there's closed, which is spina bifida occulta. Okay, so I think about these things as open and closed. And if you think about that from a surgical standpoint, it makes things very simple for you. So this is a more complicated table, but it's kind of been broken down in a way that we look at open and closed. So we're going to start off by talking about open spinal dysraphism, and the most commonly seen open neural tube defect or open spinal dysraphism topic is myelomeningocele, and that makes up 98% of open spinal dysraphism cases that we see. Other ones include a myelocele, a hemimyelomeningocele, and a hemimyelocele. I'll tell you, the bottom three I have never encountered in clinical practice or in training. Closed spinal dysraphism, we'll go through these categories a bit later on, but I want to spend a majority of our time today talking about myelomeningocele. So when we talk about normal embryology of the spine, the most important process that we talk about is neurulation, which is really fancy for development of the brain and the spinal cord. When you talk about closure of the open neural tube, it typically happens first in the upper cervical region, and then it extends down to L1, L2, and then it comes back rostrally towards the nasion. These kind of slides here show you the general embryology of this area, where you have a flat neural plate that's surrounded by ectoderm. And as this process happens, that neural plate folds and that ectoderm comes into a position that's superficial or superior. And the third plate shows a normal neural tube that's completely closed, surrounded by neural crest cells more superficially, and then the ectoderm on top of that. Now, primary neurulation describes the term for the spinal cord formation all the way to the lower lumbar level. And abnormalities in primary neurulation lead to myelomeningocele formation, lipomyelomeningocele formation, intraspinal dermoid and epidermoid cysts, and split cord malformations, all of which I'll talk about later. So don't get hung up on the terms too much. This process of primary neurulation typically occurs at days 18 to 28 of development. The caudalmost aspect, again, below the lower lumbar level, undergoes what's called secondary neurulation. And that happens between days 28 and 48 of development. And this typically is two processes known as canalization and subsequent regression. So when we talk about canalization of the spine, this is really this caudal cell mass, and it forms the distal spinal segments as well as the nerves that encompass and go with these segments of the spinal cord. When we talk about regression, we talk about involution of a partial aspect of this caudal cell mass, which involutes, and it forms the filum terminale, which is really the distal aspect of the spinal cord, and it doesn't routinely have function in it. So after the filum terminale is formed, the vertebral canal actually grows faster than the neural tube. And so oftentimes a routine question for fourth-year medical students and interns is, well, at what age does the conus medullaris ascend to its anatomic position? And typically this happens at about 3 months. So at birth, the tip or the bottom of the conus typically occurs at between L2 and L3, can be as low as L3, L4, and at 3 months of age, again, as that vertebral column grows, but the neural tube is not growing as quickly, that changes to its position at L1, L2, which typically stays at for the rest of their life. And so that's a common thing to recognize, especially as you work up neural tube defects and spinal dysraphism, to see if there's tethering of the spinal cord, because you want to look at the location of the conus. So let's jump right into open neural tube defects. So open defects have deficiencies in the overlying skin, and they have bone defects, meningeal defects, and or nervous tissue, which leads to a direct communication between the lesion in the central nervous system and the external environment. The most common form is a myelomeningocele, and this is where there's a focal segment of the structurally abnormal spinal cord exposed in the midline of the back. This is an example of a child born at full term via spontaneous vaginal delivery, prenatal diagnosis of myelomeningocele, elected to undergo postnatal closure. And you can see on this image here, this is the neural placode, which is really the exposed elements of the central nervous system, covered by an arachnoid layer here. There's also some evidence of dysplastic skin in this area as well. Sorry, I just saw someone raise their hand. Is that something that I need to address now, or would you like me to wait and to the end?
It's entirely up to you.
Okay, how do I do
Here,
that?
let me- you can go ahead and you should be unmuted now if you want to ask your question.
Good afternoon, sir.
Hi, yeah, sorry, you're just coming in. Can you repeat?
Yes, I'm from India, Vishal Gill.
Hi
Did you
there.
have-
What question
Yes,
can I answer?
yes, sir. Sir, the slides are not visible.
the slide? What was that?
Oh,
Can you?
he said he's having trouble seeing the slides.
Yes.
Oh. It looks on my end, I can see your slides. I'm not sure.
I thought maybe he's not sharing, but as he just said now, I thought maybe problem in my screen.
Yeah, sorry. It says I'm sorry. It says I'm screen sharing.
Yeah, I can see. If anyone else has any issues, let us know. But yeah, it looks, I can see everything you're presenting.
Okay.
I can try logging in on my phone and seeing if it's an issue with being an attendee versus a panelist.
Okay. Do you want me to hold off and wait here for a second?
Other people are saying the slides look fine. So I think it may be an issue on your end. I apologize. I will try to look into it, but why don't we go ahead and continue for now while I work on this in the background.
Problem.
Okay, I'm sorry about that.
Okay, sounds good. Yeah. Hope it works out. Yeah, so so this is the neural placode surrounded by, this arachnoid layer. This is all dysplastic ectoderm, which is really unhealthy skin. So this is a really good illustration of a classic myelomeningocele requiring postnatal closure. So the birth incidence of myelomeningocele is really 0.1 to 0.2%. There's a big movement now, and it's really wonderful about just really primary prevention of open neural tube defects and fortification of really all diets across the world with folic acid or folate has provided significant reduction in the number of open neural tube defects, specifically myelomeningocele that we're seeing. And the recommended daily allowance for women of childbearing age is 400 micrograms per day. Should be noted and definitely something to think about in counseling is that the risk of myelomeningocele is increased to almost 3% if there's a history of a previous child born with an open myelomeningocele as well. So when we talk about the embryological origin of this, again, just kind of speaking in generalities, the neural plates fail to fold and fuse into the neural tube, and it remains as a flat tissue plate called the neural placode. The placode is interposed between the superficial cutaneous ectoderm, which really can't meet in the midline, and the mesenchymal elements, which typically act as a barrier and protectant both structurally and physically, are not present. So the bone, the cartilage, the muscle, they're unable to migrate because they're not getting the correct signals and they're subsequently absent. So interestingly enough, the exposed dorsal surface is the interior of the spinal cord because of that flat nature of it. And I'll show you this in a cartoon. The exact embryological cause is really multifactorial, likely due to multiple factors, environmental, genetic, potentially. And so we don't exactly have the answer to this. But when we look at a cartoon and kind of display this is really a wonderful cartoon here. You can see this is a surgical cartoon indicating the scissors and a knife here, but this is the neural placode, and you can see that it's flat, and this outer surface that's exposed to the world is the inner surface of the spinal cord. And so you can see these plates, this neural plate has not folded properly to form a tube. These are nerve roots, and they may be normal, they may be dysplastic, we're not quite sure. here. And you can see there's absence of the normal bony structures. The vertebrae ends really in the pedicle here. There's no articular pillars, there's no facet joints. You can see that there's an absence of cartilage, and the muscle is atrophic in this area as well. So when we talk about management, antenatal diagnosis is really the mainstay given the technology and access to prenatal care that we have today. Maternal alpha-fetoprotein, or AFP, is sampled by blood testing, typically done during the early portion of the second trimester. An elevated AFP level can be predictive of a higher chance of a neural tube defect. Now, there are certainly other congenital anomalies that can have an elevated AFP, but if the predicted risk is higher than a specific threshold value, and that is typically 1 to 500, then high-resolution ultrasound is performed. Ultrasound or fetal MRI. Ultrasound can identify the level of the lesion, the presence of lower extremity deformities, and actually movement, Chiari2 malformation, and hydrocephalus, all of which I'll talk about, so don't get too caught up on that right now. So when we talk about counseling after an antenatal diagnosis of myelomeningocele, counseling is very important, and this can be carried out by obstetricians and maternal fetal medicine physicians, but typically it's done by pediatric neurosurgery. And the reason is because we're the ones caring for these children after they're born. And so for parents that choose to carry to term, the long-term morbidity, and specifically the neurologic and non-neurologic morbidity, should be understood and clearly delineated. First and foremost is hydrocephalus. Hydrocephalus, where there's an increased amount of cerebrospinal fluid in the brain and difficulty with drainage of this, whether it's overproduction or under absorption. It's a condition that needs to be dealt with and treated if it's present, and this can require either placement of a ventricular to peritoneal shunt, which is the most common treatment and most historic treatment, and now there's newer treatments including endoscopic third ventriculostomy with or without choroid plexus cauterization. So this ultimately, in up to 90% of children with myelomeningocele, will require attention at some point, and it's a very important topic. Lower extremity dysfunction. This is typically based on the level of the lesion. So prenatal ultrasound and fetal MRI are really wonderful at telling us the level of the lesion. And based on this, we can make educated guesses and predictions. And in fact, ultrasound can be quite accurate in determining the level of function that a child has just based on routine ultrasound. Urinary continence and incontinence, based on the level of the lesion, whether or not the child will have any semblance of continence, and if not, what that looks like for long-term in terms of clean intermittent catheterization and subsequent need for monitoring for kidney disease and things like that. Same deal with fecal incontinence in terms of the neural structures. They're intimately related with both of those phenomenon. Kr2 malformation is a Chiari malformation, which is herniation of the cerebellar tonsils and tissue. Kr2 is very specific to children who have myelomeningocele. And so there are certain implications associated with this, including brainstem dysfunction, ventilator dependence in very severe cases, cranial nerve dysfunction, sleep apnea, things like that, and cognitive impairment. So there's lots of things that need to be discussed very openly with the family when it comes to myelomeningocele. So when we talk about perinatal care, things that we want to know are the size of the lesion, and how big is the defect? Is it 1 by 1, 2 by 2? If the child is born and the sac or the placode is ruptured, many centers will initiate antibiotics, though I think this may be a little more of a historic practice. You want to cover the area with a moist dressing, and you want to keep it as clean as possible until closure is performed. From a neurological standpoint, a detailed exam, including cranial nerve dysfunction or function, is really important. Lower extremity function, we want to know exactly what muscle groups are noted. Your pediatric neurosurgery staff are going to ask you what level of the lesion is anatomically and what level of the lesion is from a function standpoint. And this is very important because it portends what kind of function they'll have later in life, specifically their ability to ambulate versus not. Do they have good rectal tone? How's their fontanelle feel? What's their head circumference? From an orthopedic standpoint, you want to look at lower extremity movement, look if there's any deformity, clubbing of the feet, scoliosis, any gibbous deformities, which is a significant kyphotic deformity in the back, as that can have ramifications when it comes to care for the child in the supine position. Excuse me, sorry. And then urologic dysfunction. So you want to, if the child is not thought to be continent, and you want to talk about getting a clean intermittent catheterization routine or schedule initiated, and routinely a renal ultrasound is done as a baseline, and urodynamics can be performed to look at the bladder contractility, its ability to fill, its ability to empty, things like that. So closure. So what's our role here? Well, if a child has an open neural tube defect, you need to close it. The reason is because you want to create a barrier between the outside world and the central nervous system. And the primary goal of that is to prevent meningitis and further neurological decline. This is typically done 24 to 48 hours after birth. There is some evidence that waiting longer than 72 hours increases bacterial colonization by a significant amount. And it's also crucial to preserve neural tissue and vascular supply as the tissue is fresh. As it becomes more friable and exposed to air, it can cause these things to subsequently necrose and cause further damage. So from a technical standpoint, the goal, whether you're doing fetal closure or postnatal closure, which is what I'm referring to now, is to close as many anatomic layers as possible. So starting on the left, you look at this cartoon here, you see separation of the placode from the arachnoid layer and the ectodermal elements. And you see this is often done sharply, minimizing cautery to prevent any loss of blood supply. Once you're able to release the placode, many people will actually reanimate the placode. And what I mean by that is actually turn this into a tube. And this is done by placing one or two simple monofilament, non-absorbable sutures to reanimate or recreate the neural tube. The next step is really dural closure. Now remember, the dura is actually involved in this tissue out laterally here, and it often blends with potentially fascia or muscle fibers out laterally as well. So the goal is to really harvest whatever dural tissue you can and provide a closure of this area. Some centers may augment with a patch to help close this as well, and that's really up to the surgeon's preference. The next thing is to close the muscle and the fascia as much as possible, and to close skin as well. So when we talk about postoperative management for these children, this is, for the most part, this is pretty regimented across centers. You may see some variation, but in general, patients remain in the prone position for about 48 to 72 hours. A barrier dressing or a mud flap is used to prevent any urinary or fecal contamination. Typically get daily head circumference measurements to monitor for hydrocephalus, and routine ultrasonography is done as well. Again, routine bladder catheterization if indicated, and both orthopedic and urological evaluations are performed. This is just a screenshot of an algorithm that's followed in a neonatal unit. You can see essentially this care is quite protocolized with very little variation across centers. So when we talk about comorbid conditions, we touched on a few of these before. So hydrocephalus is a major one. It really develops in 60 to really 90% of myelomeningocele patients that undergo postnatal closure, and up to 10% have evidence of hydrocephalus at birth. Most children who are going to develop hydrocephalus do so before 6 months of age. And why do you think hydrocephalus can develop after myelomeningocele closure? Well, when you're that really shining star on your fourth year medical student sub-I, you can say, well, it's because you've obliterated a connection and leakage of spinal fluid and brought it into a contained system, which can cause resultant buildup of cerebrospinal fluid and cause elevation of the intracranial pressure, bulging of the fontanelle, increase in head circumference, etc. Now, treatment of hydrocephalus in infants with myelomeningocele can be quite variable. There are some centers that treat right away. There are some centers that wait quite a bit, and I think that's probably, coming more into favor as we learn more about the thresholds for treatment. But in general, treatment for hydrocephalus in infants that have an open neural tube defect include apnea or bradycardic episodes, symptoms of high intracranial pressure, which those are a sign of. Rapid or progressive ventriculomegaly, and this is either detected on ultrasound, but more typically on clinical examination based on a rapidly rising head circumference, or OFC. If there's CSF leak from the closure site, certainly you want to eliminate any technical problems that may have been available, but typically this is a sign that the pressure head from the cerebrospinal fluid is increasing, and it may be a sign that the child requires CSF diversion. If there's significant hydrocephalus in the setting of a symptomatic Kr2 malformation, and again, I'll talk about the Kr2 coming up here, which is a really important category to talk about. And if there's a presence of a spinal cord syrinx, which tells neurosurgeons that the cerebrospinal fluid may be looking for an alternative pathway to exit into, and intraspinal, creating a syrinx can be associated with neurological dysfunction. So if that's starting to happen, then placement of a shunt or treatment with ETV CPC would be a reasonable thing. So someone had posed a question about survival. When you talk about survival without treatment, meaning without closure, the survival rates are low. And the reason is that significant meningitis and neurological decline can set in. When you talk about in modern day techniques and surgical closure, there's nearly an 85 to 90% survival rate. But 10% of those children will die before 6 years of age. And this is becoming more rare. And this is typically due to a symptomatic Kr2 malformation. And late mortality in patients with myelomeningocele is typically due to shunt malfunction, and more commonly in the setting of sepsis or kidney failure due to chronic hydronephrosis in the setting of urinary dysfunction. So when we talk about neurological function, 50% of myelomeningocele patients are ambulatory with bracing, and nearly 75 to 85% of patients are able to achieve satisfactory dryness with clean intermittent catheterization. And nearly 3 to 10%, up to 10%, have normal urinary continence. And it's important to remember that. That's why it's so important to understand the continuum of disease that myelomeningocele and open neural tube defects bring to the clinical table. So I've talked in depth a bit about the Chiari-2. So on the left, this is an example of a sagittal T2 MRI scan in a child with myelomeningocele who underwent postnatal closure. And you can see the significant herniation of the cerebellar tonsils into the subaxial cervical spinal canal. And associated with this is herniation of the brainstem contents. And that's unique to Chiari-2 patients in general. You can certainly see it in the setting of what's called a Chiari 1.5, but I wouldn't concern yourself with a nuance like that. On the right, this is actually a patient that has a open neural tube defect that was closed postnatally and doesn't have a Chiari-2 malformation. So you can see that there is a wide range here. And the reason that a Chiari-2 malformation is really significant and causes morbidity is because the brainstem, as you all know, is really the relay center for everything. And it can control the respiratory center, our cardiovascular center, and several of the brainstem nuclei are in this area too. So if there's any kind of molestation in this region, and that includes abnormal CSF dynamics, compression at the foramen magnum, it can cause dysfunction in one of these areas. So children that have a symptomatic Chiari-2, and they're typically symptomatic with lower cranial nerve dysfunction and require ventilatory support, they suffer from central sleep apnea, and they may even be trach or vent dependent. These kids can get very sick if their Chiari-2 kind of rears its head in what's called a Chiari-2 crisis. So those kids, in my mind, are very sick and need urgent attention if those come to your clinic or your ER. When we talk about shunt malfunction and failure, we tell people that within 5 years, 50% of children who have a shunt require some kind of shunt operation. Now, that may be a bit lower now based on some of the more recent data that's published, but in general, this is still a number that's very commonly used. And children who have myelomeningocele who require a shunt are often very shunt dependent. This is an example of a teenage boy who a right-sided scan showed a well-appearing scan. You can see small ventricular spaces. The left scan shows a very ill teenager, same kid in the ER, nausea, vomiting, bradycardic, and concerning for acute hydrocephalus. And you can see there's not much change in the ventricular caliber or size, and you might look at this and say, no, this looks okay, look at another source. But it's always important to look at a failure scan and see what a baseline scan looks like. And this child was taken to surgery and was under significant pressure, underwent a shunt revision, and was discharged home in completely normal condition the same day. So shunt failure can present quickly, it can present rapidly, and sometimes fatally. And so you have to have a high index of suspicion in these children. When we talk about other late chronic conditions, spinal cord tethering, and this is something we'll talk about in depth with some of the closed neural tube defects as well, but I wanted to introduce the topic here. By definition, children that have undergone closure of a myelomeningocele, their MRI has the appearance of a tethered cord, meaning that their conus is going to be at a low-lying level because of their congenital abnormality. So this is a picture of a child on the right, a sagittal T2 MRI scan. You can see the conus medullaris. It's a little hard to make out probably on the screen, but it ends really towards L4, L5. And so when someone undergoes an MRI and say they have a tethered cord, I don't particularly jump, because tethered cord is not just a diagnosis of radiographics, it's a clinical diagnosis, and you'll hear that through and through your neurosurgery training moving forward. Symptoms of spinal cord tethering can be quite broad. They include scoliosis or curvature of the spine, changes in muscle tone, weakness, spasticity, changes in urinary function or bowel function, and things like that. So when we see children in a multidisciplinary spinal clinic or spinal anomalies clinic, as it's called in some institutions, these are all things that we ask about. It's not just, oh, do you have headaches? How's your shunt working? Let's take an MRI scan. It's a myriad of symptoms that really require both a clinical evaluation and radiographic confirmation or adjunct more than anything. I just want to spend a few minutes talking about fetal surgery in the setting of myelomeningocele. I think it's important in today's training setting that, most people will train at a center where they do some aspect of fetal surgery, or they're developing a fetal surgery program. It's becoming popular, and because of that, I think having a general knowledge about it is really important. So fetal surgery for myelomeningocele, the advent and wide adoption of fetal surgery is really based on a multi-center randomized control trial. So this is level 1 evidence, not something we have a ton of in neurosurgery, but this is one thing that we do have. This is based on the 2-hit hypothesis that was really made popular by Dr. McClone, and fetuses with myelomeningocele are at risk for losing additional neurological function, and this is called the 2-hit hypothesis. So the first hit is thought to be this congenital anomaly, and there's basically herniation of these spinal elements, and then the second hit is that the neurotoxic intrauterine environment causes further neurological decline. So the thinking is that fetal surgery in some way can prevent this. So in carefully selected patients, fetal surgery can decrease the risk of hydrocephalus, preserve lower extremity function, and increase the chances of ambulation when compared to postnatal repair. This was the MOMS trial criteria, which is the randomized trial that I'm referencing. And if those of you who haven't looked at this, I would encourage you to at least read the abstract and become familiar with it, because it's really a seminal paper in pediatric neurosurgery. You can see the very strict inclusion and the even more strict exclusion criteria for this study. So these are very carefully selected moms and fetuses that are candidates for surgery. The tenets of fetal surgery are the same as postnatal surgery. So you want to achieve a multi-layered watertight closure. It's important to understand and realize when you're counseling that fetal surgery is not a cure for myelomeningocele. Myelomeningocele is a congenital condition that requires lifelong care. And it's important to convey that. When you look at the combined fetal and neonatal mortality after fetal myelomeningocele repair, it's 3 to 6% at experienced fetal treatment centers. Fetal surgery increases the risk of many things, including pregnancy-related complications, premature labor, premature delivery, the hysterotomy needed for open hysterotomy closure for fetal repair can increase the risk of rupture in the third trimester and in subsequent pregnancies, which is a life-threatening complication for the mother. So some factors to consider is that at screening, fetuses that have severe ventricular enlargement and lower extremity function that's poor are really poor candidates for fetal surgery because they get all the risk and are unlikely to get any of the benefit. Despite the benefits of prenatal surgery, postnatal surgery is still the safest treatment option for both mother and fetus. And prenatal counseling by experienced neurosurgeons is really critical in treating these patients. So prenatal counseling, if mother and fetus are both good candidates, then counseling should include fetal surgery. It's best to use a shared decision-making model, which really focuses on the individual self-determinism. And the approach allows patients to participate and understand their decisions and have a voice in their own care. It recognizes really that people have differing needs and values and risk tolerance when it comes to these things. And so an informed decision can be made. This is an example of a counseling algorithm for prenatal diagnosis of myelomeningocele. And I think it encompasses really all the contingencies that we need to think about. And when you talk about fetal closure, again, I told you it's very similar to postnatal closure, with the exception that you're operating on a fetus from 23 to 26 weeks of age in a gravid woman. And it takes a considerable effort to get this done, including maternal fetal medicine, really quarterbacking things, pediatric cardiology, pediatric surgery, obstetricians in place, and really you're planning for the worst case scenarios and all of these things. So it really takes a concerted effort, and I can't highlight that enough. So I want to kind of finish up the talk, probably the last 10 or 15 minutes or so, and hopefully we'll have some time for questions as well on closed neural tube defects. So going back to this initial slide that I had previously talked about, closed neural tube defects or closed spinal dysraphism really kind of boils down to different categories. And again, I like to think about things really simply. So when I think about a closed neural tube defect, I'm going to ask the question, okay, is there a dorsal subcutaneous mass or is there not a dorsal subcutaneous mass? So those with a dorsal subcutaneous mass include those with a lipomyelomeningocele, a lipomyelocele, terminal myelocystocele, and a meningocele. Without a dorsal subcutaneous mass, you can have what's called a lipoma, which is different than a lipomyelomeningocele, though they probably occur along a continuum. And among lipomas, there's a lipoma of the phylum terminale. There's what's called a chaotic lipoma, which is interspersed with the nerves. And there's a dorsal lipoma. There's a tight phylum terminale. Disorders of the notochord include a persistent terminal ventricle, a dermal sinus tract, a dorsal enteric fistula, a neuroenteric cyst, a split cord malformation. There's caudal regression syndrome, and then segmental spinal dysgenesis. So when we talk about occult spinal dysraphism, one term that I'm going to just throw out there, and again, all of these occult spinal dysraphism cases, they're characterized in general by an intact epithelial layer. So they are closed. So there's not an urgency to take care of these things unless there's leakage of spinal fluid or things like that. So Spina Bifida Occulta, you're going to see this term seen a lot on radiology reports, on consult requests, and things like that. And it's a commonly seen abnormality where there's an absence of a spinous process or lamina of L5 or S1. It's an incidental finding, and there's really no action needed. When you think about closed neural tube defects, what you want to keep in your mind is there are reasons to intervene and there's reasons to observe. The reason to intervene is if there's a meningitis risk in the setting of, let's say, a dermal sinus tract where there's a punctate connection and lesion with the outside world, and if there's spinal cord tethering or concern for spinal cord tethering. I'm going to talk about a few of these things kind of in case-based form here to finish out the talk. But what I want to bring your attention to is tethered spinal cord syndrome can occur in a congenital sense. So in the setting of a myelomeningocele, a lipomyelomeningocele, a spinal cord lipoma, a fatty filum terminale, or a split cord. They can also occur because of a spinal cord injury. So in the setting of trauma, they can also occur in the setting of a tumor, metastatic tumor or primary tumor. They can also occur in the setting of an infection, bacterial meningitis, tuberculosis, fungal meningitis. They can also occur in the setting of ionizing radiation or postoperative adhesions. So there's lots of causes for tethered spinal cord syndrome. So just because you've diagnosed someone as having a tethered cord doesn't mean they have a congenital problem, and vice versa, okay? So clues to diagnosis. So you can see cutaneous features that really appear in the midline. And this can include, in the setting of a lipomyelomeningocele, a subcutaneous lipoma. A sacral dimple is typically a sign that there's some kind of abnormality underneath that needs to be investigated. Hypertrichosis, or a hairy patch in the area. Skin tags, or a cutaneous hemangioma. This is an example of a young girl who has what appears to be a cigarette type burn in her lumbosacral area. But this actually, upon further evaluation, was actually what's called a meningocele manque, or an atretic meningocele that had involuted, but there was an abnormal connection, and she actually presented with signs and symptoms of tethered spinal cord. So when you talk about the neurological symptoms associated with tethered spinal cord, there can be a wide variation in symptoms. So you need to keep a high index of suspicion. Symptoms of tethering include lower extremity weakness, radicular pain, sensory deficits, hyporeflexia, which can appear to be asymmetric, spasticity, bowel bladder function, and non-radicular pain. Other signs include scoliosis, as I mentioned previously. Upper motor neuron signs typically come from ischemic cord damage from tethering, so they're typically mediated a little bit upstream, versus lower motor neuron signs can actually be from local compression or nerve injury. So anomalies in the bone can include bifid vertebrae, laminar defects, hemivertebrae, sacral aplasia, and sacral agenesis, and oftentimes these are associated with tethered spinal cord. And we can also see them in the combination of foot deformities. I get a lot of consultations from my pediatric orthopedic surgery colleagues because kids come in with limb length discrepancies, lower extremity atrophy, toe walking, limb pain, and scoliosis. And oftentimes it's a harbinger of an occult spinal dysraphism. Anorectal anomalies can also be associated with closed neural tube defects, and associated anorectal and urogenital disorders can happen in 10 to 15% of all patients with anorectal anomalies. And this can include cloacal exstrophy, and imperforate anus, bladder exstrophy, and Vader syndrome, which you all know what that is. So I'm going to just spend the last few slides just going through a few cases, and then hopefully we can spend some time talking about some of the questions that you all have. So this is an example of a lipoma. So this is a dorsal lipoma in the setting of an 18-month-old male who presented with early onset scoliosis. Now, he was seen by our orthopedic surgery colleagues, and they did their scoliosis films. And in addition to the scoliosis, they found that there was several levels that included hemivertebrae, and this red arrow kind of indicates this right here. And the dorsal lipoma, which is bright on this T2 sagittal image, as they always are. And he was diagnosed with a dorsal lipoma with a fibrofatty phylum terminale. So this child not only had a low-lying conus, but also had a dorsal lipoma and setting of scoliosis as well. We chose to detether this child by removing the lipoma and sectioning the phylum terminale. So meningocele. So this is an interesting case. This was a newborn male with no prenatal diagnosis of a neural tube defect, born via spontaneous vaginal delivery, and he was found to have a large fluid-filled mass on the posterior neck. So this is a image of the mass itself. And you can see here, it does appear to be fluid-filled, kind of a pedunculated mass on the aspect, the dorsal aspect of the spinal, midline spinal column there, and subsequent MRI image demonstrated this. So this would be a dorsal, a closed neural tube defect with a dorsal subcutaneous mass. And you can see here the MRI was performed to ensure that there was no neural elements involved in the mass itself. And this turned out to be a simple meningocele, which was resected on day of life 3. And the baby did very well and continues to do well with no neurological deficits to date. This is another example. This is a child who presented to me from a pediatric surgery colleague, an 8-month-old female with anorectal stenosis who was found to have a tethered spinal cord and a small syrinx and a fatty phylum terminale on screening MRI of the L-spine without contrast. You can see on this sagittal MRI, which is a T2 weighted image, you can see the small syrinx within the spinal canal, and at this level here on a T1 image, you can see this bright white area here. It's probably a little hard to appreciate on Zoom, but that's indicative of fat. And this child had a fat phylum terminale, which we sectioned to detether this child due to the presence of a syrinx. Split cord malformations. This is another closed neural tube defect that will likely present later in life, secondary to spinal cord tethering. There's 2 types of split cord malformations. Type 1 is where there's 2 dural sacs and an osseous or fiber spur. And these children are usually symptomatic in the way of scoliosis or spinal cord tethering, urinary dysfunction, lower extremity dysfunction, pain, dysesthesias, things like that. Type 2 is where there's a single dural sac, and this is complete or incomplete cord division, and these children tend to be less symptomatic. A dermal sinus tract. This is a closed neural tube defect that does require treatment at some point, and this is really to prevent connection with the outside world. So this was a newborn with a dimple in the lumbar spine above the coccyx. It was investigated with an MRI scan. You can see an anomalous connection here. Basically, this yellow area is showing you a tract with basically continuity to the outside world, as you can see here on this axial MRI, which is T2. And in addition, on day of life 2, there was actually occasional clear fluid that was draining from the tract. And so this child was taken to surgery for obliteration and removal of that tract and primary closure of the neural tube and defect in the dura and to prevent further meningitis. So I ended a few minutes early here. So in conclusion, spinal dysraphism is a really interesting topic. There's really a wide continuum of pathology. You can think about these things very simply as open and closed. I would consider the signs and symptoms of neurological dysfunction and take it in conjunction with imaging findings. Regardless of treatment, whether or not they require surgery, children with spinal dysraphism require routine surveillance and care. And at this point, I'm happy to take any questions, and I'd like to thank you guys for inviting me to speak today.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.